Hi, I'm Dr. Linda Kirilenko, and I've been asked to talk to you today about some of the most common office conditions encountered in orthopedics and hand surgery. These include entrapment tendinopathies, including triggered digits and deep Quervains, as well as lateral epicondylitis among elbow tendinopathies. Tendinopathy is defined as a painful condition of a degenerated tendon, as opposed to tenosynovitis, which is truly an inflammation of the tendon sheath. Entrapment tenosynovitis was formerly called stenosing tenosynovitis, and inflammatory tenosynovitis, as you're well aware, is pyogenic, which is the flexor tendon sheaths you encounter in the emergency room, or non-pyogenic, which are common in conditions such as rheumatoid arthritis, amyloidosis, calcific tenosynovitis, gout, and CPPD. The pathophysiology of entrapment is really a mechanical problem. There is a mismatch between the tight fibroosseous retinacular sheath and the tendon itself. The repetitive motion of the tendon through the sheath produces changes in both tendon and sheath, including hypertrophic fibrotic changes in the retinacular sheath, and classically asked on in-service and other examinations is the change is fibrocartilaginous metaplasia of the inner surface of the A1 pulley in conjunction with tendon thickening, nodularity, and attritional changes. Symptoms, as are common in many orthopedic conditions, include pain, swelling, and crepitus. Initial management is always conservative at first, including ice, splinting, activity modification, and injection is a mainline treatment. Ultimately, if conservative management fails, we move on to surgical decompression. The pathophysiology and pathology involved in triggered digits involves a abnormality of what is the normal function of the retinacular pulleys and tendon excursion. The pulleys are at the joints and they are there to permit mobility of the tendon and enhance force generation. Trigger digits are non-inflammatory. They involve intratendinous swelling and pulley degeneration. Some of the pathologic changes you can see in the pulley include cyst formation, splitting of the fibers, lymphocytic or plasma cell infiltrate, inner surface fibrocartilaginous metaplasia, as just mentioned, and an increase in the percentage of type 3 collagen. Associated conditions include carpal tunnel syndrome, deep Quervains, lateral epicondylitis, and subacromial bursitis. Comorbidities known for the condition include diabetes and hypothyroid, especially gout, renal disease, and rheumatoid arthritis are also associated comorbidities, and in the presence of these three, prognosis tends to be more guarded. Demographics: females are much more commonly affected than males, up to 2 to 6 times as frequently. The dominant hand is more commonly affected. Age demographics incidence is 55 to 60 on average in terms of the frequency of digits affected. The thumb is affected more commonly than the ring finger, which is affected more commonly than the middle finger, small finger, and the index finger is affected least frequently. Incidence in the general healthy population is 2.2%, and in those with insulin-dependent diabetes, it is significantly increased at approximately 10%. Symptoms of trigger digits includes painful locking on range of motion. Range of motion is usually possible. Occasional manual reduction or manual straightening of the locking in severe cases is required. And due to the avoidance of maintaining flexibility in the finger due to the painful nature of the popping, sometimes PIP joint flexure contractures can develop secondary to capsular stiffness. Differential diagnosis includes foreign body in the MP joint, tendon sheath neoplasms, anomalous sesamoid tendons, snapping of a tendon on an osteophyte associated with degenerative change at the metacarpophalangeal joint, and occasionally it can be mistaken for Quervain's or EPL tenosynovitis. Relatively rare causes of triggering occur more distal in the digit to the A1 pulley. You can see profundus triggering at the A3 pulley. This is often associated with abnormalities at the sublimis decussation. In up to 22% of patients affected by rheumatoid arthritis, you can see this abnormality distally in the digit. As far as treatment implications, if this is present, you may need to do an extensile approach and remove both or one slip of the FDS to resolve the condition. Grading of triggers was described by Green, indicating a stage 1, which is just tenderness at the A1 pulley with no discrete triggering. Stage 2 is catching or triggering, but mobility remains intact. Stage 3, where the digit locks but is passively correctable. And stage 4 is where the digit is in fact locked and remains so. The treatment, again, always begins initially conservatively. This is often affected. And in 7 to 9%, there's a complication estimate after, or an estimated rate of complication after surgery. So you should always start simple and then move to invasive procedure if necessary. Among the reported complications after surgery include infection, sensitivity of the scar, flexion contracture, stiffness, injury to the digital nerve, recurrence of the deformity, or development of bowstringing. Splinting, I use this predominantly in patients who refuse injection, and it's felt that if you get them early enough, this can be successful. You can either splint with the MP joint in 15 degrees of flexion, where improvement is seen in about 66% of patients, compared with the 84% who improved with injection. Or you can do DIP extension splinting for 6 weeks, and if you get to it early enough, this has been estimated to have up to a 55% resolution rate. Injection, in general, results are excellent. To 1 or 2 injections with up to 80% having resolution. The ideal patient has a primary trigger digit without comorbidities, recent onset of symptoms, 1 digit involvement, and a palpable nodule at the A1 pulley. Poor prognosis again with comorbidities. And in these patients, the way I approach it is if they fail 1 injection, I recommend surgical release of the A1 pulley. The technique these days are done in our orthopedic hand surgery treatment room. Lidocaine is used as a local anesthetic. A 25 to 27 gauge needle is used for the injection. Chloroprep is performed, after application of ethyl chloride for topical skin refrigeration. And injection can either be done above or below the tendon in the sheath, but outside the tendon. Complications of injections are rare. You can have tendon rupture, which may be delayed up to 2 to 4 years. Pulley rupture, which may result in bowstringing, depending on which pulley is involved. Hyperglycemia. You should always remember to counsel your diabetic patients to follow their blood sugars more closely over the next several days and not be concerned about a small or moderate increase that's transient. The anatomy of the pulley system. Digits have 8 pulleys, 5 annular and 3 cruciate. Pathology and trigger digits occurs at the A1 pulley. There is a fibroosseous groove in the volar metacarpal head where the tendon traverses and which is covered by the A1 pulley. Again, a testable question is what the A2 and the A4 pulleys are considered critical in maintenance to avoid development of bowstringing. The thumb has 2 annular pulleys, one at the MP crease and one just proximal to the IP, and one oblique, which is felt to be the critical pulley in the thumb. It is continuous with the adductor pollicis, and this fibroosseous tunnel is even narrower due to the presence of the sesamoids, which are in the FPB insertions radially and ulnarly at the thumb MP joint. When you're planning on injecting or operating on the triggered digit, it's important to know some topographical anatomy. The A1 pulley in the thumb is at the MP crease, and in the ring and small finger at the distal transverse palmar crease. In the index finger, it's at the proximal transverse palmar crease, and in the middle finger, it's midway between the two. An alternative method of identifying the presence of the A1 pulley is to measure the distance between the crease at the proximal interphalangeal joint to the crease at the metacarpal phalangeal joint, and then measure the same distance into the palm, and this is essentially where you should find the A1. Surgical incision options include transverse, longitudinal, or oblique. The transverse is felt to produce a better scar and may provide less scar sensitivity as it avoids all bony prominences. Longitudinal incisions produce better exposure and delineation of the junction of the A1 and A2 pulleys. Just make sure, as in any other procedure, that you don't cross the skin creases longitudinally to avoid possibility of skin contractures or scar contractures. The oblique incision is a compromise between exposure and scar. Just remember that in the thumb, the digital nerves, especially the radial digital nerve, is endangered because of the anatomy. At the MP crease, it's very superficial and is easily injured, and you can also get it as you slide the scissors proximally as the radial digital nerve obliquely crosses the flexor tendon sheath. There are some common anatomic variations. In 40 to 60% of patients, there is continuity of the A1 and A2 pulleys, so there's really minimal distinction where the A1 ends and the A2 begins. And there's an annular variable pulley described in the thumb, which is between the A1 and the oblique pulley. And in fact, there are 3 subtypes of the annular variable pulley. Open release, local anesthesia under in the treatment room, range of motion immediately postoperatively. Rarely you can wind up with some flexion contracture, but this most commonly occurs if there is a pre-op flexion contracture. Normal unrestricted use of the hand at 3 to 4 weeks. If they do have a flexion contracture or severe scar sensitivity, may need to contemplate occupational therapy, but usually the scar sensitivity resolves gradually with time, but that's something you should save yourself the grief post-operatively with by advising the patient that they can anticipate that the scar will be sensitive for a while. Complications: open release, digital nerve injury, scar pain, incomplete release. This is one of the major advantages of the way we do the procedure these days with local anesthesia, because the patient can range the digit for you immediately and confirm complete resolution of the catching. Can also, as mentioned previously, develop a PIP flexion contracture. Bowstringing is a theoretical complication, but rarely happens. Up to 25 to even 50% of A2 pulley incision usually is tolerable without development of bowstringing. Percutaneous trigger finger release, I think, is really more of historical interest. I haven't seen one in years, especially now that we do this so quickly with the standard open procedure under local anesthesia in the force-out treatment room. Before you even contemplate this procedure, you need to make sure that there's a full active range of motion so that the patient can perform this for you at the completion of the procedure to make sure you've done a complete release. Therefore, obviously, no stage 4 triggers can be considered for this procedure. And a word of caution: in patients on renal dialysis, they tend to have particularly poor prognosis with percutaneous releases, and the prognosis is most associated with stage of the triggering. Main complication after percutaneous release is incomplete release. Long-term patient satisfaction is good, with upwards of 74 to 94%, and this can be compared with some studies that have shown up to 26% patient dissatisfaction with the standard open procedure, largely due to the frequency of minor complications. Contraindications to consideration percutaneous release is when the triggering occurs in the thumb or index finger, and that's because of the vulnerability of the neurovascular bundles. Should you wish to perform percutaneous release, it's again done under local anesthesia, and the local anesthetic is infiltrated not only into the skin and subcutaneous tissues, but into the sheath as well. In the open procedure, the injection is only done into the soft tissues above the sheath. You hyperextend the finger to minimize risk to the neurovascular bundles. A 19-gauge needle is used. You place it through the skin into the tendon, move the DIP joint to confirm where you are, and then withdraw until there is no further motion of the needle with DIP motion. Rotate the bevel, and then sweep proximally and distally until no further grading is appreciated. And again, once procedure is completed, make sure that the patient can range the finger fully without residual catching. Complications of percutaneous release: again, incomplete release, digital nerve injury, and bowstringing, but you would have to really move that needle pretty far to get both the A1 and A2 pulleys percutaneously. Congenital trigger thumb, just a quick mention of this, it's really a misnomer. It's rarely present at birth, rarely triggers, most commonly presents as a fixed flexion contracture. Parents tend to become more aware of it as the child gets to be 2, 3, 4 years of age, and begin to explore their environment and use the hand more. There's no, the main clinical finding or pathologic finding in congenital trigger thumb is nodus node, which is enlargement of the tendon sheath and tendon at the A1 pulley. The differential diagnosis of congenital trigger thumb is congenital clasp thumb, absent or aberrant extensor tendons to the thumb, arthrogryposis or spasticity. Treatment, don't waste your time considering splinting or OT. Rarely resolves, or I don't think virtually ever resolves without surgical intervention. And it's recommended that the condition is treated by the age of 5 to prevent development of a fixed flexion contraction. Other trigger digits in children are very rare. If you do approach these, use an extensile approach, since not infrequently the classic findings at the A1 pulley that you see in adults are not present in children. You'll frequently see abnormal pathology at the decussation, and as in rheumatoid patients and adults, as we discussed previously, you may need to incise or excise, both FDS or one FDS slip to resolve the condition. And this is frequently seen in glycogen storage diseases in children. Now moving on to D. Quervain's, it's tenosynovitis of the first dorsal extensor compartment. It presents with maximal discomfort at the radial styloid, and it also involves the fibroosseous tunnel, but that encompasses or encloses the first dorsal extensor compartment, including EPB and APL tendons. The tunnel extends above the extensor retinaculum proximally, so during release you need to make sure that you go proximal. Originally it was described in 1895 by Fritz de Quervain, and it's felt the etiology is repetitive motion of either thumb abduction or wrist ulnar deviation, or a combination of the two. Demographics, 2 peaks of incidence, one in younger women who are either pregnant or postpartum, and then again in older adults in their 40s or 50s. Females are felt to be up to 6 times more frequently affected than males, and it's felt that this may be due to anatomy, and Bonnell postulated that in females there may be an increased angulation of the first dorsal extensor compartment as it crosses the radial styloid. Symptoms: pain, pain with motion, especially wrist rotation or deviation, or with thumb abduction or extension. There may be pseudo-triggering, as we discussed a little bit earlier, under trigger digits, where you feel a popping sensation as the thumb moves, not to be confused with trigger thumb. In terms of examination, there will be tenderness, again maximal at the radial styloid. There's accompanying swelling, crepitus. There can be retinacular ganglia, the snapping or popping discussed just above. The Finkelstein's test can be done, which is actually active ulnar deviation of the wrist by the patient in conjunction with passive flexion of the thumb into the palm. This will produce pain maximal at the radial styloid. Or Eichhoff's test, which is often confused with Finkelstein's, which is performed by flexing the thumb into the palm and then passively ulnar deviating the wrist. You can also assess for pain with resisted thumb extension at the MP joint, and some have felt that this may be a not specific but possible indicator of septation involving the extensor pollicis brevis tendon. You can also assess resisted APL function at the CMC joint. Conservative treatment, you always start with splinting, rarely effective and may increase stiffness. Anti-inflammatories or acetaminophen, heat, ice, home exercise program, and stretching. First dorsal extensor compartment is the site of most anatomic variation in the upper extremity, with less than 20% of people having the classically described one slip of the APL tendon and one slip of the EPB tendon. In 5 to 7% of patients, there's no EPB. The APL usually has 2 to 3 slips, which insert variably at the base of the first metacarpal, trapezium, volar carpal ligament, opponent's tendon, APB. 30% of patients are felt to have a bony ridge and or septum separating the APL and EPB tendons, and it's felt that up to 80% of those patients who have septation will fail injection due to inability of the steroid to access the EPB sheath. There can be an occasional transverse third compartment, and there can be tendon abnormalities that can also produce the condition. 50 to 80% of patients resolve with 1 or 2 injections, less successful as in triggering with patients with comorbidities like diabetes, rheumatoid arthritis, hypothyroidism. Injection technique, inject soluble corticosteroid, palpate a fluid wave in the APL to make sure you're in the right spot. Reserve a little bit at the end of the injection to use into the EPB sheath, and you can do up to 2 injections 4 to 6 weeks apart, which is similar to the protocol for injection management of trigger digits. Complications, 5 to 10% of dark-skinned individuals can develop depigmentation, and they should be advised that this is a possibility. Most of the time this will resolve. A less frequent but more significant complications, probably skin atrophy and fat necrosis, and very, very rarely skin or fat grafts are required to remedy the situation. Surgical technique, again, this is something done in the force-out treatment room under local anesthesia. And again, there's various surgical incisions that can be made. It's felt that the best scar is produced with a 2 centimeter long transverse incision in the skin fold at the radial styloid. Make sure you stay superficial with the skin incision to allow careful identification of any crossing branches of the superficial branch of the radial nerve. Longitudinal incisions produce better exposure, but not as a aesthetically appealing scar, and it's easier to identify those branches of the sensory radial nerve. Incise the retinaculum. Some recommend going dorsally to minimize the very rare complication of volar subluxation of the tendons postoperatively, and make sure you complete the release of the EPB to the muscle belly. Confirm that you've done this by independent traction on the EPB, and make sure that you see the MP extend so you don't mistake a slip of the APL for the EPB. And then ask the patient to range the motion, to range the thumb actively to confirm no residual catching or evidence of incomplete release. Complications of surgery, incomplete release, very, very, very rarely injury to the radial artery that's very bolder to where you should be. You can get neuromas of the sensory branch of the radial nerve. There can be transection of the sensory branches of the radial nerve. There used to be some controversy about whether it was better to repair or resect, and I think the jury at this point is in, and microsurgical repair of the nerve is the preferred management. Failures can be secondary to inappropriate diagnosis where the pathology is really at the CMC joint, where you can have either arthrosis or instability. A little bit about elbow tendinopathy. We're going to talk just about lateral epicondylitis. It was originally described in 1873 by Runge. In 1882, it was termed lawn tennis arm by Norris. The etiology is felt to be repetitive microtrauma to the common extensor tendon in physiologically predisposed individuals. Classically, the ECRB anterior 1/3 of the EDC tendons are involved. Epidemiology and demographics, age peak is at 45 years. Dominant hand is most frequently involved. No sex difference between male and female in terms of incidence. Pathophysiology, it's a degenerative tendinopathy, non-inflammatory. Merchel proposed that it's an angiofibroblastic tendinosis, and he also suggested the initial stage was a short-term inflammation followed by angiofibroblastic degeneration of the tendon, followed by mechanical structural tendon failure. There can be superimposed fibrosis and calcification. The cause, again, is usually repetitive microtrauma. Some have theorized that there may also be ECRB irritation by abrasion of the capitellum. The normal sequence of development is you have a normal tendon which is traumatized. It attempts self-repair. This results in fibroblastic collagen deposition and vascular proliferation. In the setting of ongoing trauma, there's continuing symptoms, and it's an endless cycle. Presentation and exam, the pain is usually at the inferior lateral epicondyle. Pain is increased with resisted or with wrist extension, and clinical exam most commonly performed is the tennis elbow test, which is requesting the patient extend the wrist against resistance provided by the examiner. Also described with the chair test, where you can have the patient lift a light chair while they're standing with their elbows extended and forearms pronated. This will produce pain. Can also test for forearm supination with a flexed wrist against resistance. Some people suggest that you may be able to differentiate lateral epicondylitis from radial tunnel syndrome by using the resisted middle finger extension test, but I haven't found this to be particularly helpful. The conditions that are potentially in the differential diagnosis, so radial tunnel syndrome and lateral elbow arthrosis. Diagnosis, ask about the history, ask about occupations, avocations that might increase risk. Do the physical exam that we just talked about. X-rays are really only done for exclusionary purposes if you're on the fence about whether there may be osteoarthritis concomitantly or instead of tendinopathy. You can also assess for soft tissue calcification or enthesophyte formation. Soft tissue calcification can either be secondary to pathology, or if they have a history of previous injection, may also be secondary to the injection. Very rarely, MRI can be contemplated, and you'll see increased signal on both T1 and T2 images. The differential diagnosis, again, elbow arthritis, periarticular neoplasm, loose bodies, but again, in loose bodies, most commonly, you'll have locking or other mechanical symptoms. Has also been mistaken for cervical radiculopathy, elbow instability, and radial tunnel or supinator syndrome. Treatment. Boyd and Hastings commented that there is much witchcraft and pseudoscience involved in the treatment of patients with lateral tennis elbow. I think the consensus, we are evolving now to a benign neglect approach where we just advise the patient that symptoms should resolve in 8 to 18 months with activity modification. Sometimes patients are not really satisfied with that response. And then treatment modalities that are available include physical therapy, ultrasound, pulse electric magnetic field, and extracorporeal shockwave therapy. Tyler twist exercises, which are available on YouTube, are recommended. Some type of brace, counter force, or above and below elbow bracing, or even cock-up wrist bracing is sometimes recommended. Injection can be contemplated, and ultimately from calcitrant symptoms can contemplate or consider surgical intervention. Non-op is the mainstay with 85 to 90% of symptoms improving, although up to 40% of patients will not have complete resolution of their symptoms. Recommend anti-inflammatories, icing, activity modification, use of a splint cock-up wrist brace at night or during the day, counterforce elbow brace, corticosteroid injection. When the pain is improved, you can consider therapy, either formal or at home. And if the patient is high demand, the therapy progression would really be isometrics and stretching to progressive resistant exercises, and then sports-specific or work hardening. Injection options, Botox, PRP, prolotherapy, autologous blood. The downside is the time, and a lot of insurers won't cover this. Dry needling, which is sometimes performed by a physical therapist. Botox, downside is muscle weakness. Corticosteroid injection may be of some short-term benefit, but it's not seen to have any impact at 3 or 12-month follow-up. And recent studies have shown no difference compared with corticosteroid versus local at 1 or 6 months. And it's felt that the technique of injection is more important than the substance that's actually injected. And the goal is to stimulate a healing response in the tendon. Surgery can be done with persistent symptoms after 6 months of conservative care. Open surgery has a relatively high patient satisfaction rate, with 90% being satisfied after first surgery and 83% even being satisfied after revision surgery. The surgery involves debridement of the ECRB or the ECRB EDC interval with decortication of the lateral epicondyle and repair of the tendon. You can simply release the ECRB tendon. You can do this through a small percutaneous open incision. You can also denervate the lateral epicondyle. In the hands of experienced arthroscopists, arthroscopic debridement is also an option, which has been shown to have a high patient satisfaction rate and is felt to demonstrate a faster recovery. This needs to be counterbalanced with the possible incomplete nature of the release performed. And remember to stay anterior to the midline of the elbow joint to preserve the lateral omicrolateral ligament. And post-operatively sling for a couple of days, get them moving right away, but avoid resisted wrist extension for a few weeks. And that's it. Thank you for your attendance, and hope you learned something. Have a good day.